Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the Med Edit podcast, hosted by me, Dr. Jessica Gray.
And me, Dr. Cari Sorrell. Together, we will provide real, evidence-based medical information that will empower your health decisions, answer your questions, even the cringeworthy ones, and help you navigate the overload of information related to health and wellness.
Let's sprinkle a little laughter and a whole lot of knowledge into your day.
Hello, friend. It's good to be back together.
Yes, it is, Cari, and I'm super excited about our topics today. Probably not as excited as you might be, considering this is probably one of your favorite topics to discuss ever, but I am very excited nonetheless.
You are not wrong. If there is one thing that I love to talk about, it's colon cancer screening. Also, I get to have one of my good friends on the show to help review the options that are out there.
And after we hear you and Dr. Vanessa Costilla discuss colon cancer screening, we will hear both of you weigh in on our Hollywood hype segment about colonics.
Ooh, yes, Colonics, a Hollywood favorite and seen on multiple episodes of The Real Housewives, Shaws of Sunset, you name it. Well, if there's one thing more fun than having one GI doctor on our show today to talk about these topics, it's going to be having two. Colon cancer screening, not only my favorite dinner party topic, but a very important topic for us all.
Stay tuned after that because we discuss if roto-rootering your colon is the way to go in the Hollywood hype. Today, we welcome Dr. Vanessa Costilla on the show. She is a full-time gastroenterologist who works for University Medical Center, running a very busy practice. We are so lucky to have her here with us today.
Welcome to the Med Edit podcast, Vanessa.
Hi.
Now, Vanessa, we go back a bit, almost a decade now. We trained together in what feels like really a lifetime ago, and we're both primo poop doctors now.
Is that what you guys call each other now, as primo poop doctors?
I just made that up.
I love it.
Yes, I know. I'm so glad that we are in the same city and get to practice and still run patients by each other like we did as fellows. And it's such a blessing to still have good friends in Lubbock, which sometimes, is hard to imagine that we both would end up here, but here we are.
Absolutely, you're right. And Vanessa, today we're going to talk about colon cancer screening. So just so our listeners are aware, March is Colon Cancer Awareness Month, which is why we want to take some time to review the options. It is the third most common cause of cancer in both men and women in the United States. There will be 150,000 new cases of colon cancer this year and 50,000 deaths. Unfortunately, because of many factors, including diet and lifestyle, the risk of colon and rectal cancer are increasing, especially in those less than age 50.
Wow, that is so many.
Yeah.
It really is. I was looking at those numbers, 150,000 new cases of colon cancer this year and 50,000 deaths. That's actually higher than I thought it was.
Yeah.
Yes, that is so true. And this is why screening is so important.
Dr. Costilla, tell us, who should be getting screened for colon cancer?
So any average risk individual at age 45 should have a screening for colon cancer. If you have a family history of colon cancer or colon polyps, you need to talk to your doctor because you could potentially need a colonoscopy before age 45, as you are now considered high risk. A high risk individual would be someone with colorectal cancer or an advanced polyp in a first degree relative. So a sibling, a parent, even a child at age less than 60, or colorectal cancer or an advanced polyp in more than 2 first-degree relatives at any age.
And tell us, what's an advanced polyp? When you're saying that, for me, I'm primary care and family medicine. Patients will come in and say, well, I had a couple polyps on my last colonoscopy. Tell us how I can talk to my patients, or if as a patient, what's an advanced polyp?
So an advanced polyp would be a large polyp. So anything greater than 1 centimeter or 10 millimeters is considered an advanced polyp. Or if it has, and this is more doctor talk, if it has a villus component, so basically it means it's kind of a little further along the pathway to become colon cancer. And so then that is also considered an advanced polyp. And so those individuals get their repeat colonoscopies done even sooner because we just have to keep a closer eye on them.
So I always remember from med school, the villus component, we're supposed to think like a villain, like it's a bad thing.
Yep.
Yes.
So it's a bad polyp. So if the patient doesn't know, you don't know what happened.
Yes.
From your colonoscopy, you don't quite remember all the pathology and stuff, they can always ask their doctor and look for some of those words maybe, or ask that question.
Yes, exactly. And you're right. So many patients don't know exactly what type of polyps they had. They just No, they had some. And so, as a gastroenterologist, we make it a really good point to say, hey, this is why you need to have this repeat colonoscopy, because it was closer to becoming cancer than we would like, or it's a more aggressive type polyp than the usual polyps. And so I try to use that verbiage with my patients when discussing their colonoscopy results.
Absolutely. And just of note, we're talking about different ages during this episode of when you should start doing things. And this has somewhat changed for us in the last few years. But if you are one of those high risk individuals, then you may be even younger than 45. You may be 40 or even younger, because those people, we tend to start about 10 years before that relative that was at high risk. So it could be, you may think, oh, I'm in my 20s or my 30s. I don't need to worry about this yet. But this is why you need to start talking to your doctor about it, because you may be one of those people who is before 45.
I'm one of those people, actually. I have it in my family, and I've gone to actually Dr. Costilla, and I was like, hey, so there's these family members that had all these things. And so she's like, okay, so it's going to be in your 30s and it's not in your 40s. So even when you're like, I don't have any worries about these problems, going and talking to your primary care doctor or your gastroenterologist is really important for those conversations.
Yeah. And it used to be 50 for so long too. So permeating that information out into the community that it's not 50 anymore. And for some of you, it was never 50. You should have been doing it a while ago is super important.
Absolutely. I think that 50 marker is so important, because I tell my patients, they come in, I say, hey, you turned 40 this year. Great. We're starting mammograms, but I already should have told you that was starting. But in 5 years, we're going to be starting routine colon cancer screening. And so every single year at the annual, I say, guess what? At 45, the colonoscopy is coming.
Yes.
It just makes them a little more comfortable, because by 45, they're like, yes, you've been talking about this for 5 years. Get it over with by now.
Absolutely. And that is a question that we all get very often, you and Vanessa and I as well, is, what happened to this age change? And the reason that it changed actually in the last few years is that at least roughly about 10% of all colon cancers and 15% of all rectal cancer diagnoses are occurring in individuals under age 50. And although rates of mortality or death related to colon cancer declined over age 50 by what our interventions are doing, they have doubled for those age 20 to 49. And that's why that change was made, to decrease the age to 45.
I mean, Vanessa, are you seeing more of those 20 to 49-year-olds diagnosed with colon cancer? Can you give us a little bit of maybe an example or some background on what you're seeing in that age range?
Yes, it's honestly been shocking at how many advanced polyps I've been finding in young patients. I remember this young farmer who came to me for rectal bleeding. He thought this is just hemorrhoids, and it was a very large polyp that actually had cancer already inside of that large polyp. Thankfully, with the colonoscopy, I was able to remove the entire polyp, including the cancer, so he didn't require surgery. But what's interesting is that motivated his parents, who had not yet had their screening colonoscopies, to go and get their first colonoscopies. They were already in their 60s. He was about 32. And so that was motivating. His whole family came to me and got their colonoscopy, and including his younger sister, who was in her 20s. Because her 32-year-old brother had just been diagnosed with colon cancer, right? So she had to get hers, in her 20s, her first colonoscopy. So we're seeing a lot of that. And I've had 23-year-olds with advanced polyps. So even some of our, colleagues who come to me and like, oh, I found out my brother had a large polyp, and I find these polyps in young, very healthy people who you would not expect, people who live very healthy lifestyles, who exercise and eat right, and still we're seeing these advanced polyps, and it does make you take pause, and maybe even makes me want to have my colonoscopy a little bit earlier. So.
We talk about this all the time. These of us that train together, and if we have cases that surprise us or we're not expecting, we talk about them just for, learning for all of us. And I feel like that's one of the topics that we all have been talking about a lot lately, is the younger and younger that we are seeing these large polyps, because we do colonoscopies for other interventions or other indications sometimes, So it could be diarrhea or constipation or something that you're not expecting to find polyps. And so many of these, I remove large polyps and think, man, if they'd waited until the age that we start screening, like what that polyp would have looked like. And There's no way to predict that in some people, but we definitely, I think all of us have seen an increase in that.
That's crazy. That really is. So Vanessa, what testing options are recommended or available? Because my patients will come in, and yeah, even though I've been talking about them with the colonoscopy for like 5 years straight, prepping them on what a colonoscopy is and how it's not as terrifying as everybody makes it sound like it is, but they want to know all of their options so they can make an educated decision on what they can do. Or maybe they're not a good candidate for a colonoscopy because of some issue with anesthesia or blood thinners or some other medical condition. What are the options out there?
So we do have quite a few options, I think, compared to what we did even just a few years ago. So options that have a strong recommendation behind them include FIT testing, which is fecal immunochemical testing every year. And basically that detects blood in a stool sample using antibodies. This is different than the FOBT, or fecal occult blood test, which uses a chemical guaiac to detect blood. Colonoscopy, of course, every 10 years allows us to directly visualize the colon. That's an option. There's a few other ones. Everybody has seen the Cologuard commercials, I suspect, which is basically multi-target stool DNA testing every 3 years. And it looks for basically abnormal DNA and blood in a stool sample. Other alternatives include flexible sigmoidoscopy. So basically this is looking at part of the colon, not the entire colon, but then you would need to repeat this a bit more frequently, about every 5 years. There's imaging, which is a CT colonography, which frankly, you still have to do an entire bowel prep to get this test done. And we use basically special CT to look at the colon wall. And you would still need to have this done every 5 years if that's the route you chose. And lastly, there's now even a capsule colonoscopy that's available. And I have not utilized this myself, and I'm not sure that it's really gained a whole lot of traction, maybe only in those patients who had incomplete colonoscopies for other reasons. But that is also one for every 5 years.
Can you tell us again about the Cologuard, and then maybe what are some of the limitations? Because I think right now patients are really deciding between the two things. They're saying colonoscopy and Cologuard. So who is somebody that would be a good candidate for a Cologuard? And tell me again those recommendations.
So I would say, in terms of the differences, I think the biggest thing that you have to remember is colonoscopy is the only test that is going to prevent colon cancer, because we are basically finding precancerous polyps and removing them. We visualize them and take them out, and we prevent colon cancer. Cologuard, though it is it is still quite sensitive for colon cancer. It is not very sensitive for precancerous polyps. It only catches about 42% of precancerous polyps. And those are actually advanced polyps. So that's probably even some of the other more less advanced polyps it is not capturing at all. And so I will say that colonoscopy, if you're a high risk individual, so if you have a family history of colon cancer, you should be having a colonoscopy, not a Cologuard. And the indications, even Cologuard will say, if you're high risk, this is not the test for you. And unfortunately, I think what I find most frustrating is lots of times either an insurance company or somebody doesn't appreciate that this patient is a high risk. They should have never even been given the option of a Cologuard. And they have this false sense of security when their Cologuard is negative, that they're fine, right? And the truth is that they're not, that was not the appropriate test for them. And so I think getting the community to really realize that not everyone qualifies for Cologuard. If you're an average risk, meaning no family history of colon cancer, then the Cologuard is okay for you. And you would need to do that at least every 3 years is what we currently recommend. But otherwise, colonoscopy is the way to go if you certainly are high risk.
Yeah. And I know you've probably seen some of the data that I've seen too, that they may eventually decrease that interval to less than 3 years from what we've seen.
Yes.
2 at the most here pretty soon.
Oh, interesting.
That's something that's been looked at ongoing. And one of the other things that's being looked at ongoing too is potentially blood testing. So that's kind of on the horizon for colon cancer. Some listeners may have heard of these tests. Probably going to say this wrong, but Septin 9 or epiprocolon, which uses DNA to detect colon cancer. It is actually FDA approved right now, specifically for somebody who has declined all other modalities. So like basically if you are, nope, not going to do it, then it's FDA approved for you, but there's just not a lot of long-term studies currently. And I don't know how everyone else feels about this, but I agree with Vanessa. When you look at the comparison of all of these, I don't want to just detect early onset cancer. Like if I'm the patient, like I want to remove precancerous things before they become cancer. So that's, as a patient, what would drive my decision is that if I have an option, the only option that's going to prevent, that's the one I'm picking. But again, we've told you what's approved and who it's approved for.
Well, that's the same thing we talk about breast cancer, right? We never usually find a precancerous breast lesion. When we find a lesion or a lump, we find cancer. It's there. You don't get that choice.
Right.
If you had the option to do something or maybe do a special kind of mammogram that detected pre-breast cancer, I feel like patients would be much more on board with it. Unfortunately, because sometimes, we're talking about booties and bums and poop related to colonoscopies, people get all scared and they're like, no way, I don't want to do that. But if it was another option that wasn't invasive, I think that, or maybe just not something taboo, a discussion,
right,
then people would be more willing to do something that really could help find a precancer.
Absolutely.
But I'm going to ask one for both of you guys, but Vanessa first, what can someone expect in preparing for a colonoscopy?
So I will say there's no nice way to clean out your colon. Okay, cleaning out your colon is a challenge no matter how you slice it. I will say though, there's so many prep options now. I think everybody imagines the gallon jug of Go Lightly that everyone used to get, 10 years ago. And now there's just so many good options for bowel preparation that are much more tolerable. And honestly, I really do kind of change my prep depending on the patient, right? Like, of course, if there's patients who've had bariatric surgery and can't handle large volumes, like we alter the preparation for that. If you're somebody who has chronic constipation, I will choose potentially a different prep for you. So I will say that it's so much easier now than it used to be, in my opinion. I think there's so many more prep options. And I will say the biggest thing I hear from my patients after the colonoscopy is, oh, wow, that wasn't as bad as I thought. And I think everybody is happy at the end of the day that they did it. I really can't say that I've had anybody that, oh, I regret my colonoscopy. I wish I hadn't done it. Like everyone is so grateful to have had it done and relieved to have gotten that, box check. So Dr. Gray will leave them alone at their office.
I will.
Yeah, I agree. So many options now. And it's definitely, if you are nervous about doing something, you want to talk to your doctor about, because, we've all done things like, even like I have a patient who's like, no, I can't do it because I vomit with everything. Well, we've got some ways that we can try to get around that. So just don't write it off because you're worried about the prep of it. We only have one way to clean out your colon. So whatever we give you, you've got to poop. If you've got poop in you, I can't see anything. So there's no point in doing the test in the first place. So you got to get cleaned out, but we have ways to do that and ways to make it easier. And the other thing I will say, the plug, when you get those instructions, is the diet changes you're told to do are just as important as the prep you're told to take. We have studies showing that. There's even some studies in some countries where they do no prep, but a diet change. Now it's more strict than what we do, and their clean out's pretty darn good. Ooh. So when we tell you to do those things, it's not because we're trying to torture you. It's because we have data behind it that it makes your prep better, which means I see more and it's a better test for you.
They say that the reasons why they don't want to do it or they're pushing it off. Number one is the prep. So you've already addressed that. We can tailor a prep to you. We can make your own cocktail tailored to exactly what you can tolerate. Number two, they say pain. And then three, the cutest one I heard from somebody I personally know is that they don't want to toot afterwards. Can you guys address the last two maybe to make some of my patients feel better?
I will say patients don't have pain after a colonoscopy. It's unusual for patients to have any discomfort after a colonoscopy. During a colonoscopy, we do insufflate or put air inside of the colon so that we can see and make sure we examine the lining of the colon thoroughly. But most good endoscopists will suction air out as they're coming as well to kind of minimize any discomfort you have. Another kind of technical aspect of colonoscopy is probably 10 years ago, room air is what we used to kind of insufflate the colon. And that used to cause a lot more discomfort, especially people would have cramping and pass a lot more gas. Now, most endoscopy centers use CO2, and basically that dissipates from your colon much quicker and causes very little discomfort. And so people are not usually tooting after their colonoscopies as much as they used to. So I think people usually enjoy the propofol nap. That's what we usually use to sedate you for your colonoscopy. It's a very refreshing nap. And, people wake up feeling refreshed, like I said.
Absolutely. And Once you get there, so we've talked about the prep you do beforehand, the adjustments that we make. Once you get there, again, you'll meet with somebody who helps put you to sleep, whatever their credentials are. And then basically you get put on your left-hand side. There's good reasons for that as well. I know people are like, oh, that's my bad side. So there's good reasons for why we do that. You'll be put to sleep. We do the procedure. You wake up. You get to go home. Like, it's easy peasy. So absolutely, I think that you've run out of excuses not to have it done. Basically, we've answered all those questions.
So there's no downtime either. I guess that was the other one that sometimes they ask is their downtime. And I use one of my colleagues she works with me as an example. She was like, no, it was the best nap of my life. I know why Michael Jackson overdosed on this stuff. She had no pain, felt great. And she was at the mall later that afternoon and had a steak dinner.
Yeah. As long as you have someone to drive you, then, go for it.
So what symptoms could someone have if they have colon cancer? Because that is one of the common ones as well, as they will say, I don't need a colonoscopy. I don't have any symptoms. I don't have colon cancer.
So I think the most important thing to take away from that is that sometimes people have colon cancer and do not have any symptoms. Depending on the location of the cancer, it can take a long time for you to develop symptoms. For example, if a tumor is located in the right side of your colon, you will probably not see bleeding that occurs because of that cancer. It will kind of get mixed in your stool and you're not going to see it. And so it's possible for you to have no symptoms. So this is why we do screening. I tell my patients, I cannot look at you and tell you if you have colon cancer or not. I can't tell if you have polyps. This is why we screen everybody over the age of 45 or even sooner if you're high risk. Now, the alarm signs is what we call them, changing in your bowel habits, rectal bleeding, if you have weight loss that's unexplained, new onset abdominal pain that you didn't have before. Those are all alarm signs and symptoms that you should then definitely consider doing a colonoscopy, no matter what age. Like I said, the youngest colon cancer I've seen recently was about 23 years old. And a lot of times I've seen moms who just had babies and they thought, oh, I have hemorrhoids. This is why I'm bleeding. And they wait too long, unfortunately. And I have found metastatic thin colon cancer in 30-something-year-old women who thought it was just hemorrhoids. And so any of those alarm symptoms should definitely push you to have your colonoscopy.
What are some things you as the patient can do to decrease your risk of colon cancer?
So there is new evidence regarding use of aspirin. This in the past used to, we had some data a while ago, but more recently, this has finally made it into our actual GI guidelines that they say taking low dose aspirin, even 81 milligrams a day, can result in you making fewer polyps and less colon cancer. And so that is something I'm definitely now recommending to my patients, especially if I do their colonoscopy and they have several polyps. They ask me, what can I do differently? I'm so healthy. I eat so healthy. Why did I make all these polyps? And so aspirin 81 milligrams a day is definitely one thing that they can do.
Yeah. And I know that you just mentioned about eating. So diet is also important. We have, again, studies. I know we say that a lot on the show, but we like evidence. So studies that show that diets that are higher in red meat consumption or processed meat leads to an increased risk of colon cancer. And that processed meat can include a meat that's been smoked or cured or salted, preservatives added. And, one of the questions I always get is just like when you mentioned, limiting alcohol is, well, how much is too much? Which is a great question. Something we need to keep looking into, but there are some experts, and actually I've gotten a lot of this information from international guidelines. So Europe, for example, who has recommended less than 500 grams a week of those meats that I mentioned. There's also evidence for high fiber diets, which really we say that kind of for all cancer risk, but diets that are higher in fiber decrease the risk of colon cancer as well.
Based on some of the things I've read as well, I've usually counseled my patients. The recommendation is 3 times a week or less of red meat would be a good way to look at it. If you're not good at calculating grams or you're not sure what that steak would look like.
Unless you're in West Texas.
I know,
Make sure they know what size steak you're talking about.
Jessica. That's a good point. Look at like your fist size versus, your size of the steak. But 3 times a week or less would be what we were kind of saying for there too. But okay, we've talked about when you should clean out your colon and have it checked. But what about having it cleaned out for other reasons? We have seen multiple Real Housewives episodes, and even on Shaws of Sunset, they were talking about colonics.
It has seemed to be a very popular treatment in Hollywood and something I get asked about every so often. First, we will talk about what a colonic is, why people have it done, and we'll finish up with the risk. Vanessa, do you ever get asked about colonics for constipation or detox or whatever reason?
Yes, I do. And fortunately, I feel like it's become a little bit less common in my practice, thankfully, but it's definitely a question I've gotten more than I would like.
I've gotten it from a family member before texting me, and I was like, "Do you mean colonoscopy
Yeah.
or?"
Yeah, they were like, no, I don't. So colonic irrigation, they actually use large amounts of water, sometimes up to 16 gallons,
Oh my gosh.
and possibly other substances in there, such as herbs or coffee, and it's flushed throughout the colon. Usually this is done using a tube inserted into the rectum.
Okay, to be honest, this does not sound like fun. This sounds like waterboarding your booty. For this, why would someone consider having one of these done?
Yes, so usually you are. And the proponents of colon cleansing believe that toxins from your GI tract, your gastrointestinal tract, can cause a variety of whole body health problems. They believe that colon cleansing improves health by removing these toxins, maybe boost your energy or improve your immune system. Now, this make me unpopular to say so, but there is no evidence that colon cleansing produces these effects or is beneficial. I'm going to go on record by saying that.
I'm going to
Great.
on that one, just like all these liver detoxes, which I'm sure both of you guys can attest to those too, or the kidney detoxes. Your body does that for you. It doesn't need you to detox for it. It figures it out yourself, and flushing out anything like your colon and waterboarding it is just not helpful. And again, we have two experts here in gastroenterology and liver specialists too, who are saying that there's no evidence these are beneficial. And can you tell me, is there any risk that it could be actually harmful?
Yes, absolutely. So coffee enemas, which are popular in some groups, sometimes used in this colon cleansing, have also actually been linked to deaths, either due to infection or imbalances that it's causing. That, like you said, your body is a fine-tuned machine, and then we're causing imbalances in things like our electrolytes or minerals. I don't know if Vanessa remembers this from fellowship, but we actually took care of a patient who had rectal burns.
Mhm.
Coffee enema at home with hot coffee as well.
Oh my gosh.
Which is
Yes.
extremely painful. And so absolutely, we've seen risk with that. Some other side effects could include dehydration. You can get a tear in the rectum or a perforation. Like I mentioned, infection, changes in balances with our minerals and our electrolytes, which can be dangerous, especially if you have underlying kidney or heart disease or other health problems. Colon cleansing can also cause less serious side effects like cramping, bloating, diarrhea, nausea, or vomiting.
This sounds horrible all around.
I've really sold it to you, haven't I?
But what's the difference, just real fast?
Yeah.
What's the difference between a colonic and an enema? Because I know my patients will ask those questions, because an enema, you're also putting liquid up through the rectum. But what's the difference between those?
So I think colonics is just the amount of volume, right? Like an enema is not going to go probably all the way up to the cecum. And the colonics are basically putting massive amounts of fluid so that they're hopefully reaching, I think, the entire colon. Enema, I mean, they're both still going up your bottom, basically. It's just the volume is different.
Mostly it's volume for the most part. And then also how you administer it. Like I don't know of any enemas that you other in like a preloaded
Right.
device, whereas with a colonic, you're actually inserting a tube to pump through. So it kind of limits, again, some of those complication risk as well as how high things can get.
And an enema would be something that maybe a doctor would prescribe for you or approve for you, and you
Correct.
purchase it at the pharmacy, and it has, marketing and data and knows what it's in it. It's not going to be something that you hot coffee made in your kitchen and then decided to put up your bum.
Yeah, I definitely recommend against that for sure.
Yeah. Yes, there are reasons we use enemas for like medical reasons, but definitely not colonics.
And if you do choose to try colon cleansing, just make sure you check with your conventional medical provider first, especially if you take any medications or if you have health problems. Make sure your colon cleansing practitioner is using disposable one-time equipment. That's where that infection risk comes in.
Mm.
Make sure that you get a list of specific ingredients and amounts of what they're going to use, and make sure that you do your research about what those side effects can have of those ingredients. And if you're not sure, you can talk to your doctor about it. Although I will admit sometimes there's ingredients I even have a hard time finding information about.
Well, we have reached the end of another great episode. Thank you, Dr. Vanessa Costilla, for being here. Now you know when it is beneficial to your health to have your colon cleaned out the proper way and when it is not. Remember to ask your doctor if you need colon cancer screening ASAP. You may be already past the point that should be a discussion you've already had. So go ahead and talk to your doctor. Again, we want to thank you, Dr. Vanessa Costilla, for being a wonderful guest. Please come back and hang out with us anytime.
Thanks so much for having me.
Come follow us to learn facts about your health. Like this episode, subscribe, turn on those notifications for new episodes, tell your friends, and stay tuned.
Thank you for listening to the MedEdit podcast. Please click the follow button to be notified when new episodes become available. For more information about this episode, and to learn how you can reach Dr. Cari Sorrell and Dr. Jessica Gray, please visit today's show notes. And don't forget, click that follow button to be notified when new episodes become available. The information and content has been made available for informational and educational purposes only and does not constitute a physician-patient relationship. If you need medical advice or help, contact your personal physician. The views and opinions of the guests do not necessarily represent the views or opinions of Dr. Jessica Gray and Dr. Cari Sorrell. This podcast should not be considered as an alternative for medical advice, diagnosis, or confirmation of an illness or disease. Please seek assistance from your personal health practitioner.